Hey, thanks for joining me for this video. So you think you're having a drug reaction. For those of you who haven't watched my other videos, I'm a doctor and MD. I have a PhD in pharmacology and toxicology. I'm an associate professor of medicine. I am a fellow of the Royal College of Physicians and Surgeons of Canada and a fellow of the American College of Physicians. Most importantly for this video, I'm a clinical pharmacologist. A clinical pharmacologist is someone who specializes in patients who do not have the average response to drugs. They either don't respond enough or they respond too much. If you think about the average response to drugs, we are pretty good at designing drugs now that achieve just about the right benefit in the majority of patients that are taking them. The problem is that response to medication follows what we describe as a Gaussian distribution. And within any population of patients who take a drug, there's always going to be some who don't get enough benefit and others who get too much or have an adverse reaction to their medication. This video is for patients who may be having difficulty with their medications. You may think that you're having an adverse reaction to your medication. This video is for doctors who want to improve communication strategies around adverse drug events, and for pharmacists who also may benefit from some of the information here. We're going to talk about the fact that adverse drug reactions are a common problem and that they prevent patients from getting the most benefit from their medications. On one hand, it's bad to have something bad happen to you, but it's also bad if it means that you stop taking a medication that could potentially help you, because then you're not taking anything that's helping you, and that can also be bad. We're going to talk about how to figure out if the symptoms that you're having are related to your medication, and a little foreshadowing here. Don't use the package insert. I can think of other things that the package insert might be good for other than figuring out if you're having an adverse drug reaction. We're going to talk about how to respond if you think you're having an adverse drug reaction. And then we're going to talk about some examples of using medications where, by using them well, we can manage or avoid adverse drug reactions. And I'll use some information from some of my patients in the hypertension clinic. Adverse drug reactions are a common problem. The estimate is that somewhere between 1 in 200 to 1 in 100 older individuals who are taking medications may end up being admitted to hospital in any given year because of an adverse drug reaction, or at least because an adverse drug reaction contributes or prolongs their hospitalization. The estimate of death from drugs varies widely, and there's another video on this channel about that. But the estimate may be that approximately 1 in 2,000 of the total population dies each year related to medication use. On the other hand, a lot of patients die because they don't get access to good medication. And the risk of death can be because of a toxicity related to a medication, but it can also be because of lack of effect or because a patient inappropriately discontinues a medication that they think that they're having an adverse reaction to. In older patients, there's a clear association between the number of medications the patient is taking and the likelihood of being admitted to hospital with an adverse drug event. One of the big things to think about in this topic of adverse reactions to medications is the issue of association versus causation. As humans, we are programmed to make association between things that happen in our lives. The issue is that many of the associations that we make are not causative. There's a Latin saying, post hoc ergo propter hoc, which translates to after this, therefore because of this, i.e., if one thing follows another, then the latter thing was caused by the former thing. The problem is that that is not true much of the time, and it's actually called a fallacy. An example of that would be, for those of you that enjoy YouTube and like to think about vaccines, the topic of vaccine hesitancy is often, I think, related to this inappropriate association, or thinking that one thing is caused by another. So many people will say, oh, I know so and so who had a vaccination, and it wasn't long after that that they became quite ill. They had a fever, they didn't feel well. Therefore, I don't want to take a vaccine. Well, you take vaccines during flu season. And so it's quite possible that you would end up with a viral infection that would make you sick. And the fact that you had a vaccine beforehand implies to us that maybe the two things are linked, whereas in fact, they probably aren't. It seems that a lot of people on YouTube know someone who got autism after receiving a vaccine. And so there's lots of people that claim that there is a causative relationship between vaccines and autism, whereas that is absolutely not true. It's been debunked many times over, and yet people still like to believe it because as humans, we're geared to think that if I had a vaccine and I get autism, the two things must be linked. No, they're not linked. The fact that one thing happened after another doesn't mean anything. And so a large part of this topic is trying to understand the science behind causality. There's a tremendous amount of effort that's been put into coming up with ways that we can establish when a reaction happens to a medication. Is that reaction being caused by the medication, or is it just happening alongside a patient who happens to be taking a medication that may be helping them? When a patient says, Doc, I had a drug reaction to one of the medications that you gave me, I think quietly to myself, in the causality literature, that would be called global introspection. One of the scales that we use to determine causality when it comes to adverse drug reactions is called the Naranjo scale. There's a number of factors that we think about when we're thinking about whether a reaction is related to a medication or not. This is a list of some of them. So the first would be a previous association. So if a drug is known to cause skin reactions in some patients, and I give that medication to a patient and they develop a skin reaction, there's a previous history of that increases the probability that my drug actually was responsible or caused the skin reaction. The timing of the reaction to when the drug was started is important. If a reaction predated the use of the medication, then it makes it much less likely that that reaction is related to the medication. If a reaction happens with the very first tablet that you swallow, that's often not related to the way the drug is working, because we know that medications take a while to build up in your system to start to cause reactions. And so I have many patients that come and say, Doc, I took after swallowing the first tablet, I had this horrible reaction. Well, I can confidently say to most of those patients that reaction that you had was not caused by the drug. Another thing we often do is a de-challenge. So if a patient is experiencing a particular side effect or reaction, if we take the drug away, does the reaction get better? That would be cause a positive de-challenge. We often will recommend a re-challenge. So, if it's not a life-threatening reaction, if you go off the drug, the reaction goes away, then we will re-challenge you with the drug. And if it comes back again, then that sort of confirms that it's more likely the reaction is being caused by the drug. Dose response is important. So if you take a dose of an opiate and you feel slightly sedated, when you take more of that, you become more sedated, then you can say, the sedation probably is a reaction to that medication. On the other hand, if taking more of the drug doesn't cause more of the side effect or reaction, then it means that it's less likely to be caused by the drug. We think about experimental data, and often when I get a patient coming in saying, Doc, I've had a particular reaction to a medication, when it's not something I've heard about or am familiar with, the first thing I do is go to a scientific database like PubMed, and I'll type in the scientific terminology for whatever the reaction is the patient's having, and then I will type in the name of the medication, and I'll just see what comes up in experimental data, either supporting or not supporting that. If the drug's been around for decades and no one has ever experienced anything like this, it makes it very unlikely that that reaction is caused by the medication, and more likely that the reaction is something else that we need to go after and figure out. Along the same lines, we think about confounding factors. So If a patient has no previous history of any skin condition and I give them a drug and they get a drug eruption, a skin reaction, then it's more likely that the skin reaction was caused by the drug. If I have a patient with a previous history of psoriasis, a skin condition, and I give them a drug and they get a skin reaction that looks like psoriasis, then that's a confounding factor, and it means that the reaction is much less likely related to the medication and perhaps more likely to simply a change in the underlying health condition causing the trouble. Okay, so let's talk about package inserts. This is just my opinion, and you can take it or leave it, but I think that package inserts, these are the patient package inserts that provide information at a patient level, are rarely helpful and are often harmful. The information in these brochures comes from clinical trial data, and then it is digested. My suspicion is by a lawyer who works for the drug regulatory agency and perhaps a lawyer from the company that would like to market the product. And they come up with some wording and come out with these documents. So I'll give you an example. I'm doing a clinical trial right now, and we record information on any adverse event that occurs in a patient in our clinical trial. And what we are asked to do as investigators in this clinical trial is to record any adverse event. So any adverse occurrence in the health of a clinical trial subject who is administered a drug that may or may not be caused by administering our study product. This includes drug reactions. So that's the definition that we're asked to adhere to when we are recording data about adverse events within the trial. So I say to a patient who's coming in for a study visit, how have you been since the last time you had a study visit with us? And the patient says, "Oh, doc, you know what? Last night I had a terrible night. I ate bad chicken. I think it was bad chicken, and I ended up throwing up all night and having diarrhea, and I just feel terrible." Well, I'm going to say to that patient, "You know what? I don't care that you think it was the chicken. That sounds like an adverse event, and I record it into our study documentation as an adverse event related to a patient being in the clinical trial." Another patient might say to me, "Oh, doc, I feel terrible. I slipped on the ice walking in here and I fell down. I broke my ankle. So now I have a broken ankle." Well, I'm going to say to that patient, that is an adverse event. And, how do I know that the blood pressure, if it's a blood pressure drug, it dropped your blood pressure? Maybe that's why you fell down. And so I record that as an adverse event. Another patient says, "You know what, doc? I have something to admit to you. I haven't been taking my medication. And when I thought about coming in for my visit with you today, I had a panic attack. I had this anxiety reaction." Well, I'm going to record that as an adverse event for a patient who is participating in this clinical trial. All of that information is written down, and that's the kind of information that will often end up in these package inserts. There's no presumption that the drug caused the adverse events, just that patients taking this drug within a clinical trial experience these adverse events. I'm serving on a data safety monitoring board for another study right now, and in this study, we're looking at patients who are very frail. And as part of my role on this data safety monitoring board, we examine every adverse event that is reported within the context of this clinical trial. And I can tell you that in this frail group of patients, there are dozens of patients, there are hundreds of adverse events. And so far, I personally don't believe that any of them are caused by the drug product being studied, but we still examine every single one of them. And all of these adverse events in these frail individuals, like broken bones, falling down, that sort of thing, will be recorded and reported as adverse events occurring in patients taking this drug in the context of this clinical trial. Okay, so we are going to go through a patient package insert for a drug that I really like. It's a blood pressure lowering medication, and I use a lot of it in my patients. Word of warning, it took me 13 minutes to get through this reading quickly and understanding all the terminology. I'm not going to bore you with all 13 minutes of this. I'm going to try to show you the highlights. Okay, so this is the patient package insert for one of my favorite blood pressure pills. It's a package leaflet, information for user, 10 milligram, 20, and 40 milligram tablets. Read all of this leaflet carefully before you start taking the medicine because it contains important information for you. Keep the leaflet. Sounds very serious. This medication has been prescribed for you only. Do not pass it on to others. It may harm them. I guess the question is, if it's going to harm them, why wouldn't it harm me? All right. What the drug is used for and what it's used for, what you need to know before you take the drug, how to take the drug, possible side effects, how to store the drug, contents of the pack. All right. So this is what the drug is and what it's used for. It's a group of medicines called angiotensin II receptor antagonists. They lower blood pressure by relaxing blood vessels. All right, well, that's good. All right. So let's see. High blood pressure can be controlled with medicines such as these tablets. Your doctor has probably also recommended that you make some changes to your lifestyle to help lower your blood pressure. For example, losing weight, giving up smoking, reducing the amount of alcohol you drink, and reducing the amount of salt in your diet. All right, what you need to know. Don't take it if you're allergic. That makes sense. If you're pregnant, if you have yellowing of the skin and eyes, if you have diabetes or impaired kidney function. The problem here is that many of the patients who are using this drug actually have diabetes. And one of the things that we know about these medications is that they improve or they preserve kidney function. And so the patients with impaired kidney function to start with are some of the patients I'm most likely to want to give this to. So that doesn't make sense to me. All right. Warnings and precautions. Talk to your doctor or pharmacist before taking the drug. If you have kidney problems, liver disease, heart failure, which is one of the reasons you'd want to use this. If you're diabetic, which is again one of the reasons you'd want to use this. Or if you are on a low salt diet. Well, up here, they told us that our doctor would be telling us to eat a low salt diet. And then down here, they're saying that this is a warning. If you're taking a low salt diet, you're not supposed to take this. I don't get it. I mean, I'm a doctor, not a patient, and I don't get it. All right, so let's keep going here. I actually did read this. It took me 13 minutes. Okay, during treatment, contact your doctor if you experience severe persistent diarrhea, substantial weight loss. Your doctor may evaluate your symptoms, decide how to continue your blood pressure medicines. As with any medicine that reduces blood pressure, an excessive drop in blood pressure in patients with blood flow disturbances of the heart or brain could lead to a heart attack or stroke. Well, this medication lowers blood pressure. That's what it's supposed to do. And now it's telling me that I'm going to have a heart attack or stroke because I'm taking it to lower my blood pressure. That makes no sense. Tell your doctor or pharmacist if you are taking or have recently taken or might take any other medicines. Potassium supplement, salt substitute, which contains potassium, water tablet, diuretics. Well, we often use this drug in combination with water tablet or diuretics. So, I mean, I like it when my patients talk to me, but that doesn't make any sense to me. All right, and then some information about pregnancy and breastfeeding. Okay, this is crazy. Driving and using machines. You may feel sleepy or dizzy while being treated for your high blood pressure. If this happens, do not drive or use machines until the symptoms wear off. Ask your doctor for advice. So the reality is that everybody feels sleepy. In fact, all of us feel sleepy every day. We go to bed and we sleep for hopefully 8 hours at least. I don't get this. Is this saying that if you're sleepy, you're not supposed to take your medication? Or is this just motherhood and apple pie that if you feel really sleepy, it's better not to drive? I mean, the signs on the freeway tell me that. I don't think you need to talk to your doctor for advice about that. But again, it makes absolutely no sense. Possible side effects. Okay. Like all medicines, this medicine can cause side effects. although not everybody gets them. If they do occur, they are often mild and do not require treatment to be stopped. Although not many people get them, the following side effects can be serious. If you notice any of the following, you should contact your doctor or go to the nearest hospital emergency department. And then they'll break them down into uncommon. And they highlight the fact that you can get pain or a tight or heavy feeling in the chest, especially when exercising, and that these signs could be problems with your heart, angina. So the implication here that I'm getting from this is that this drug causes angina, which is absolutely not at all true. You take this drug in order to avoid heart problems. So again, I don't understand what they're saying. Um, Rare symptoms, difficulty or pain when urinating, changes in the color or amount of urine passed, pain in your lower back, feeling or being sick. These may be signs of serious problems with your kidneys. Well, again, part of the reason you take this drug is to protect your kidneys. So the implication here that this drug is going to cause you to have trouble doesn't seem right. Okay, so common side effects. Well, headache. So patients with high blood pressure get headaches, and when you treat their blood pressure, often the headaches go away. So again, I don't understand. Uh, Feeling tired. Everybody feels tired. In fact, this class of medication is one of the best ones for not feeling tired. Um, and so putting that into a product monograph, I mean, just because in a clinical trial, patient said, "Oh, I feel tired today, doctor," doesn't imply causation. The drug's not making you feel tired. Sore throat, runny or stuffy nose, bronchitis, flu-like symptoms, cough. Again, these are common things that patients experience, not because they're taking this drug, and yet we're being warned about it. Urinary tract infection, again, no linkage there with the drug in terms of causation. Swelling of the ankles, feet, legs, hands, or arms. Well, I often use this class of medication in patients who have this in order to make it better. And so the implication that this drug is going to cause swelling of the ankles, feet, legs, hands, or arms is ridiculous. Okay, and then spinning sensation, vertigo, feeling unwell. Again, all this very vague stuff that has absolutely nothing to do with the drug. Maybe these are things that the patients who were in the clinical trial reported to their doctor when their doctor asked them how they were feeling. But the implication that a patient might get out of this is that the drug is going to cause these things, not that these are things that happen to people in real life. A lack of energy. So I have a lack of energy a lot of the time, and I'm not taking this. It doesn't make sense. And then the drug is supposed to cause a low blood pressure. That's why you take it. And yet you're being warned that a rare side effect of this drug is that it might make your blood pressure low. If this is rare, then why would we be using it as a blood pressure lowering medication? It makes absolutely no sense. And then there's some information about reporting. If you get side effects, talk to your doctor or pharmacist. But again, this type of information is not at all helpful to the average patient, let alone, I mean, me. I'm a PhD in pharmacology and a doctor, and I don't get it. So how could patients understand that? Clearly, the patient package insert is not a useful tool to decide whether you might have a reaction or even to know what things to look out for. So that you can compare and contrast that piece of paper to the advice of a doctor, what I tell my patients when I'm prescribing this particular agent is that there are basically a couple of small things that we need to do when patients are using this medication. One is that we need to recheck your blood work to test your kidney function and your electrolyte levels after you've been on this. When we check is determined by what your baseline kidney function is like. So if you have completely normal kidneys, I'm quite happy to check in 4 weeks, for example, after you've started on this medication and your body has grown accustomed to it. If you have poor kidneys, I might even check a week from when I initiate the drug. And obviously, if your kidney function is not great, I'm going to start at a lower dose and then work up. So we need to check kidney function. We need to check electrolytes. Other than that, this drug is extremely well tolerated. There is one very unusual reaction which can be serious and can be hard for patients or their doctors to really latch onto as a side effect of this medication, and that is diarrhea. So this medication is associated with what can become quite a severe intestinal reaction where patients get almost like a sprue-like condition where they're having a lot of diarrhea, don't absorb nutrients very well, and this can progress and become quite severe. So if you're taking this, that's the one thing you need to keep an eye out for. Are you getting loose bowels? Beyond that, you know, take it, see how you feel, let me know how you're doing. That's basically the advice that I'm going to give my patient. And then the other thing I tell all of my patients, whenever you start a new medication, if you notice anything out of the ordinary, call me. I'm the one that started the drug, and I can help you troubleshoot. Most of the time, if a patient experiences something, I can tell them right away either yes, that's drug related, or no, I don't think that's drug related. We need to look elsewhere. Okay, so we've established that the patient package insert is not a great place to get good information about medications. What I wanted to leave you with today is some information that would be useful to you if you suspect that you may be experiencing an adverse drug reaction. So the first thing I want you to look at on this graph is across the top, the benefit of the drug. Some drugs really are limb or life-saving. Some drugs are necessary, but perhaps, being off them for a few days won't be a problem. And some drugs I would classify as short-term optional drugs, things like pain medication for pain that's not terribly severe, that sort of thing. So how much benefit you're getting from a drug is one factor. The other factor is the nature of the adverse event. So when you look at this matrix, we'll go across the top. So if you have an adverse event that you feel is life or limb threatening, anaphylaxis with difficulty breathing, for example, if your drug is life or limb saving, for example, a blood thinner being dosed immediately after a blood clot in the lung that can kill you, and it's preventing you from dying from the blood clot in the lung, but now you have some other reaction. If the reaction that you experience is a life or limb threatening reaction, then when it happens, you have to go straight in for emergency support. You need a good team helping you sort out what to do next. And so you seek emergency medical attention. If the drug that you're taking is a necessary drug, but it's not the kind of drug that being off of it for a few days is going to make a big difference, stop the drug as soon as you recognize a potentially life or limb threatening reaction. And then you still need to seek urgent medical attention, but you may not have to rush right into the emergency department, depending on the circumstances of your situation. If you have a drug that is what I would refer to as short-term optional, and you have a reaction that is life or limb threatening, obviously stop the drug immediately. You're still going to need to seek some urgent medical attention because of the drug reaction, but you don't have to worry so much about the drug, about losing the benefit of that drug. If you have a reaction that is harmful in the sense that you think bad things are going to happen within hours to days, and you are on a drug that is absolutely necessary for life or limb, then you should continue the drug and then seek urgent medical attention to try to sort out what's happening with the adverse drug reaction. If you are on a drug that is necessary, but being off it for a few days is not a problem, then and you're having a harmful reaction in the framework of hours to days, stop taking the drug and then seek urgent medical attention. If you're on a short-term optional drug and you have a reaction that may be harmful in hours to days, then obviously you're going to stop the drug and seek medical attention when it's convenient to do so. If you have a reaction that is a nuisance, for example, I feel a little bit itchy, but there's nothing else that seems awry, and you're on a life or limb saving drug, then obviously stay on the drug until you can get in to see your doctor and discuss it at your next available appointment. If you are having a nuisance reaction and you're on a necessary drug, I would recommend that you continue the drug and then give your doctor a call to have a conversation, schedule an appointment for that. If you're having a nuisance reaction and you're on a drug that is what I would refer to as short-term optional, then I think stopping the drug makes sense, and then seek medical attention to discuss what your next options would be. Okay, in the aftermath of an adverse drug reaction, the most important thing that you can do is gather as much information as possible. I refer to this as the what, where, when, and how of reporting adverse drug reactions. So, the what is to gather as much information as you can about exactly what happened. If you have a skin rash, take a picture, write notes down about the details of exactly what has happened to you. The where refers to the context. Where did this happen to you? How did it happen? What were you doing at the time? Did you have grapefruit juice before you took your drug? Did you take St. John's wort and then lose the benefit of the drug? Were you traveling? Did you eat certain foods? Did you get a scorpion bite? Doctors love stories about scorpion bites. So, whatever the surrounding circumstances are that describe where this reaction happened to you, record that information as well. The when of the what, where, when, and how is really the details of timing. Timing is critical. So, you need to record how many doses you took before the reaction occurred. You need to record if it was days, if it was years, whatever details you have about when you started the drug in relation to when the reaction occurred, that information is critical. If you go ahead and stop the drug before seeing your physician, then you also need to record what happens in the aftermath of stopping the drug. So, how many days did it take for you to feel better, or did you not feel better after stopping the drug? All of that type of information is also very helpful for us when we're trying to troubleshoot adverse drug reactions. Finally, the how to report is really based on who you should be reporting this to. So ultimately, the doctor that prescribed the drug to you that you feel you may be reacting to is the most responsible person for helping you manage your adverse drug reaction. The second, perhaps most responsible person would be the pharmacist that dispensed the drug to you. And then the third most responsible person might be your primary care doctor if that person wasn't the one who initially prescribed the drug to you. This topic of who's responsible is a bit of a pet peeve for me. Many of the patients I see are started on a drug when they're an inpatient in the hospital, and they have some specialist that sees them and says, you know, you have a heart problem. I think you need amiodarone, for example. And amiodarone is a drug that requires constant monitoring in order to make sure patients can take it safely. It causes a lot of adverse drug reactions. The patient then develops some symptoms, and the doctor that started it is inaccessible. That's not acceptable. If you happen to be one of those doctors who works in a hospital setting, if you start the drug, you are responsible for the adverse reactions that occur. Let's talk about balancing the benefits of taking drugs with some of the side effects or adverse reactions that occur. And I'm going to use 3 examples from the hypertension clinic. So I have patients that take diuretic agents and report that they end up with a low sodium level. And often when I'm considering what drugs to use in a patient to treat their high blood pressure, this comes up as an issue from their past history that, oh, I was taking that diuretic before and my sodium level went down. Now, having a low sodium level can be a very serious thing. If it goes too low, you can actually have seizures. So that's not a good thing. At the best, having a low sodium level makes you feel a bit tired and sluggish and you just don't feel right. A low sodium level in the bloodstream is determined by 2 factors. One is the salt level, so how much salt is being eliminated by the diuretic that you're taking. The other is how much fluid is in your bloodstream. And as a patient, you can't necessarily control the sodium, but you can control the fluid intake. And most patients that develop low sodium concentrations in their blood when they take diuretics are drinking too much fluid. And so a simple way to manage that adverse drug reaction is to consume less fluid. And many patients, with a little bit of information, just knowing that you need to cut back on your water intake on a day-to-day basis while you're using the diuretics, then allows you to use these diuretics that can be extremely effective for blood pressure lowering safely. Another problem that I often hear is low potassium levels in patients who are using diuretics. And so the patient will say, "Doc, I can't take that diuretic. I had a low potassium level. I got muscle cramps the last time I used that medication." Well, it turns out that the effect of a diuretic on your potassium level is moderated by the amount of salt that you consume. So the more salt you eat in your diet, the lower the potassium level in the bloodstream goes, and the more muscle cramping you will get when you're taking a diuretic. So the solution to a low potassium level with diuretics isn't necessarily to stop the diuretic. It may be to simply eat less salt. And by eating less salt, you then get the benefit in terms of blood pressure from eating less salt, but it also allows you then to use these diuretics that otherwise would be causing a low potassium level. The final example I want to give you from my blood pressure clinic is related to swelling on the legs when patients take calcium channel blockers. So calcium channel blockers are a common class of blood pressure lowering medications. Examples would be drugs like amlodipine, nifedipine, or felodipine, or diltiazem would be another example. These drugs dilate the blood vessels in the veins leading into the capillaries in your legs. And by dilating those vessels, they allow gravity to work to accumulate fluid in the legs, and patients complain of swelling. The best way to manage that is to give the patient another blood pressure lowering drug, an angiotensin receptor blocker or an ACE inhibitor, that dilate the vessels coming out of the feet and allow that blood to return to the heart. And so by giving an angiotensin receptor blocker, for example, which is the drug that we looked at in the product monograph, you can lower the amount of swelling from calcium channel blockers by about 50%. So the appropriate reaction to having swelling on your ankles from a calcium channel blocker isn't necessarily to say, I've had a reaction, I can't take that drug. It's potentially to add on a little bit of an ACE inhibitor or an ARB, reduce the dose of the calcium channel blocker, and then you get the same blood pressure lowering because you're now using a synergistic cocktail of drugs without the side effect, without the adverse reaction. And so there are ways of working around adverse reactions. And I would encourage you, if you are experiencing or may be experiencing an adverse reaction, to work with your physician to try to determine if this really is a causal issue where the drug really caused this problem, or whether it may be just an association that needs to be managed in a different way. And I'm going to do other videos about that. But often by working with your physician, you can come up with a good solution that will work very well to help you take drugs that are likely to benefit your health while avoiding the adverse reactions. Thanks so much for paying attention to this video. If you enjoyed it, please subscribe, ring the bell if you want to be notified when I post new information, and share this with other people that you think might benefit. Thanks so much.
Dr. Dresser does not wish to take any responsibility for his opinions expressed in this video. Nothing in this video should be considered a therapeutic or diagnostic recommendation. If you are one of Dr. Dresser's patients and wish to be considered a good one, please adhere to everything in this video with religious fervor. If you are not one of Dr. Dresser's patients, please discuss these ideas with your healthcare provider.